100,000 new cases per annum in the UK alone. The second common cause of cancer death, though majority of patients can survive with prostate cancer depend on the stage of the disease. The incidence of prostate cancer is on the rise here. Worldwide distribution, you can see there's more in South America, North American. Risk factors. The most common risk factor to develop prostate cancer is age. The older you get, the more risk you can get prostate cancer.
Thank you.
Ethnicity, that's the price you pay. Afro-Caribbean men are more prone to develop prostate cancer. Family history, if you have first-degree relative father or brother, you have more risk. Genetics, there is association between breast cancer genes 1 and 2 with high-grade prostate cancer as well. Screening. Is screening valid in prostate cancer? We have a blood test to check prostate cancer. Now, these are just to remind you of Wilson-Junger criteria, which is essential for screening program for any medical condition. So that condition should be important health problem. We should know the natural history. We should have a test to diagnose, and we should be able to cure the patient if we pick up the disease at an early stage. We have a blood test for prostate cancer called PSA, which stands for prostate-specific antigen. It's a protein secreted by the prostate gland. The problem with PSA used for screening is a valid screening test. There's no doubt about it, and it comparably favors comparable with the mammogram in breast cancer. But the problem, till we have strong evidence that this reduces the mortality, then screening is not recommended. And it's not recommended in Europe or in UK. It's only done in the United States of America at the moment. The issues with PSA, it's a crude marker for prostate cancer because it can be increased if you have a large prostate, or if there's infection, or if there's urethral manipulation, that somebody have a catheter or cystoscopy. This is what we use in clinical practice. So what we use in clinical practice, so we use an age reference rate. There is no cutoff number. They used to say 20 years ago that if you have a PSA of larger than 4, then you have a chance of having prostate cancer. Nowadays we use a reference range. So this is between 40 and 49 years old, for example. We accept 0 to 2.5 on average. And as you get older, as you see here, it gets to 3.5, then from 70 to 79 to 6.5. And this is very interesting. So this tells you even if the digital rectal exam showed there is no evidence of cancer of prostate, and your PSA is lower than 2.5, there's a chance of prostate cancer, about 5%. So it's not a diagnostic, but it helps in the diagnosis. Molecular biomarkers. Now these all help in the diagnosis, treatment, planning prognosis of these patients. Lots of them, whether blood sample or in the tissue or in the urine. The problem with all these markers, the challenging factor, we still need large randomized trial to assess their efficacy in the diagnosis and planning treatment of prostate cancer. So it's still experimental. This is to tell you about the anatomy. Now this is the front of the body, this is the back, this is the rectum, this is the bladder, and this is the urethra, and the prostate sit here. And you can see from here, prostate cancer predominantly develop in the peripheral zone of the gland here. The risk of having cancer in the other zones like central or transition zone where the urethra pass is very low. The majority of prostate cancer are adenocarcinoma. This is the type of the cells. We use a special grading system called Gleason, where the pathologist assess the most dominant pattern with the highest grade to give us a score, like 4.5. So the minimum is grade 3, we have 4 and 5, so you can have combination of any of these. This is it's a picture just to tell you, this is a benign prostate enlargement. You see the gland is well distributed. This is the base layer of the gland is well preserved. While here, there is loss of the baseline. And it's like diffusely lots of cells here and cytoplasms, engorgement. This is all signs of malignancy. This is an algorithm of how patient present, how we diagnose. This is to summarize everything for you. So from presentation, we'll talk about this in details. We make a diagnosis with a biopsy or with MRI scan. Then we stage the disease into 3 stages. So the localized means the disease is confined to the prostate. So they either go for observation or to curative treatment, whether surgery or radiotherapy, or if it's locally advanced, we aim for local control, again, surgery, radiotherapy, or it's a metastatic disease, that means